are not well understood. And when you look at all the major macronutrients, protein, lipid, carbohydrate, the least well understood and the nutrient with the most variable practice is that of lipid administration. Intravenous lipid infusions have been implicated as a cause of pulmonary dysfunction for a variety of reasons, including hyperlipidemia. Early in the 1980s, there were studies that showed several patients died with increased lipid layering in their lungs, and it was called a fat overload syndrome, but that's actually probably very rare. What has been more clearly established is that there can be a ventilation perfusion mismatch in the lungs due to triggering of the prostanoid metabolism, which causes changes in pulmonary vascular tone. So at least 7 to 8 studies have given lipid infusions in infants and followed with echocardiography and demonstrated that pulmonary hypertension can worsen as you give lipid. However, the safe amount of lipid and rate of lipid administration in order to avoid worsening pulmonary hypertension has not been well defined. But in many institutions across this country, and across the United States at least, people withhold lipid in a baby who has pulmonary hypertension. Clearly, the effects of that on other aspects of metabolism could be very detrimental, so more work needs to be done in this area. Data is inconclusive for a variety of reasons, and mainly because people have used different study doses of lipids, have looked at different duration and rates of lipid infusion, the type of lipid study, and the type of lipid study. So at this point, there's really insufficient clinical evidence to withhold intravenous lipid emulsions for pulmonary reasons, except perhaps in infants with persistent pulmonary hypertension. Some of you may be attending the American Academy of Pediatrics and SPRPS meetings in Hawaii that will be held in May of this year. And I'm one of the several people who put together what's called the Neonatal Nutrition and Metabolism Club. And this year we wanted to try to find a speaker who could perhaps clarify many of these issues, review the literature, contact people on up-to-date research, and we were fortunate enough to get Dr. Joe New to agree to give this talk. So we've contacted people around the world to get their opinions on how this lipid should be managed in different disease states. And so I think Dr. New's talk will be very interesting, and we look forward to hearing what other investigators around the world have to contribute to trying to answer some of these questions. So if you happen to be at that meeting, please come. There's a free lunch. All right. Next slide. So what should be the lipid intake with bronchopulmonary dysplasia? Well, as has been discussed by several previous speakers, you want to have a minimal lipid intake that prevents essential fatty acid. And that amount is probably somewhere between 1/2 and 2 grams per kilo per day of lipid. Fat is an important parenteral and enteral energy source in infants with BPD. I've just reviewed several studies for publication that are giving enteral lipids of different types to tiny babies starting in the first few days of life as an energy source, and are looking at the side effects of giving early lipid to preterm infants and to see how it affects growth and other parameters. So I think the results of those studies should be very interesting. It's generally felt that the use of long-chain polyunsaturated fatty acids may improve growth and developmental outcomes in these infants, and so people often give what might be in routine formula or even some additional supplements. I've seen that reported in the literature. The optimal lipid intake is very controversial. And again, a Cochrane review showed no difference in outcomes if you started lipid very early versus waiting till after the first week of life. So we can probably start lipid administration fairly early in these patients. Next slide. We're going to talk a little bit about bronchopulmonary dysplasia, which I'm sure is very familiar to all of you. And Stephanie Atkinson from Toronto supplied me with some information and research that she has been she has accumulated over the last several years, and much of this will be her work that I'll be discussing. Broncopulmonary dysplasia has been defined as an oxygen radical disease of prematurity. Oxidative process, especially of lipids and proteins, for Dr. Ziegler, contributes to the development of broncopulmonary dysplasia. Postnatal growth failure and poor nutrient stores in the very preterm infant decrease the ability to counter oxidative stress. Next slide. Nutritional support in the very preterm infant is critical to prevent, improve, and recover from broncopulmonary dysplasia, which often is a very long-standing disease in any one infant. As a minimum, we would recommend providing nutrition in amounts recommended for the preterm infant of the same gestational age who doesn't have broncopulmonary dysplasia, and that's a minimum of what we should provide. There are currently no evidence-based guidelines for nutritional management in BPD, and specific nutrients thought to play a role in prevention, treatment, and catch-up growth have been lacking. Next slide. I'm going to talk briefly about some different strategies that people have been using over the last 8 to 10 years to try improve broncopulmonary dysplasia. Unfortunately, their benefit has been in question. The first nutrient, a nutritional antioxidant I'll mention, is vitamin E. And this is a proposed free radical scavenger that may well prevent not only BPD, but retinopathy of prematurity. Trials in humans and baboons, unfortunately, have shown no benefit in the prevention of BPD, and it's thought that this would likely really make an improvement, but that has not been shown. There was another Cochrane review that looked at, demonstrated no clinical benefit at intakes above that which maintains normal blood vitamin E concentrations. Another agent, which is a nutritional antioxidant, is N-acetylcysteine, or NAC. It acts by neutralizing hydrogen peroxide. There has been a single trial looking at the benefit of N-acetylcysteine in broncopulmonary dysplasia. And that was a large study in Scandinavia of almost 400 infants, and these babies got intravenous N-acetylcysteine for the first 6 days of life. However, there was no demonstrated benefit in the prevention of broncopulmonary dysplasia or no decrease in oxygen requirement. Next, we have another nutritional antioxidant, selenium. People have used for research purposes selenium concentration as a measure of an antioxidant status. If you have a high selenium level, you probably have at least a reasonable high antioxidant status. In a single study that was done, it was shown that very low plasma selenium at 1 month of age was associated with increased respiratory morbidity in preterm infants. However, there have been virtually no selenium studies done with its effect on lung disease since then. And again, a Cochrane review didn't show that giving extra selenium didn't decrease BPD or ROP, but there was a suggestion in a review of the literature that perhaps selenium would reduce the number of episodes of sepsis, and I've not seen any follow-up research on that thought. Next slide. Another promising candidate was thought to be inositol, and inositol has a proposed mechanism of preventing lung disease by increasing the synthesis and secretion of surfactant. It's known that there's very high concentrations of inositol in preterm infant breast milk, and it has been shown that giving inositol to babies with lung disease will actually increase the phosphatidylcholine sphingomyelin ratio in surfactant. However, in the Cochrane review again done on inositol for lung disease, they did show a decrease in IVH grades 2 and 4 and severe retinopathy of prematurity. They weren't really looking for that, but that was a finding in this study. However, inositol had no effect on BPD alone, and it was felt that more studies need to clarify the role of inositol in lung disease. So I don't want to go into detail in vitamin A, but this, of all the nutrients that I've just discussed, is probably the most controversial in terms of its use and management in lung disease. And there have been several good studies done on vitamin A and several good reviews of vitamin A use, but the results are often conflicting and people can't seem to agree on its benefit. So vitamin A, the proposed mechanism of benefit is that it's a stimulant for lung reepithelialization after barotrauma or oxygen injury. The stores of, in very preterm infants of vitamin A are low at birth. Again, a Cochrane review in 2002 concluded that vitamin A supplementation in low birth weight infants was associated with reduced death or oxygen requirements at 1 month of age, reduced oxygen needs at 36 weeks of age, and that it may also decrease the incidence of not only retinopathy or prematurity, eye disease, but also nosocomial sepsis. And the greatest effect of benefit at 36 weeks was in those babies who were less than 1,000 grams when they got treatment. When you read this, it sounds like vitamin A is a terrific idea, yet at least in the United States, there's a lot of controversy about whether to give vitamin A to preterm infants, and practices vary dramatically. And the main reason there's a problem with vitamin A is that it needs, if you're going to give vitamin A, it requires multiple doses of intramuscular vitamin A over a prolonged period of time. And so many people are concerned that many painful doses for only modest benefits probably don't justify the use of vitamin A. So in theory, at least, it should improve lung disease, but a lot of people are still reluctant to use it. And clearly there needs to be more studies in this area. So I want to change just to a slightly different topic, but in terms of its effect on lung disease. And these are further strategies to prevent lung disease. And it has been proposed that parenteral nutrition with antioxidant